We have the young and dynamic Dr. Raghav, who's going to talk to us about KLEX.
You
That's
see
a
what
new,
he has done.
Thank
yeah.
you, Gaurav sir, for this opportunity. But
Thank you.
first, before everything, I want to wish Gaurav sir a very happy birthday.
Thank you. Thank you.
Thank you for conducting this course on your birthday. So today I will be speaking about KLEX. Now, what is KLEX? So KLEX is the term that is collectively now being used by the Refractive Society, which includes all the lenticle procedures. Till now, we had a monopoly with just SMILE being there, but now we do have 4 commercially available procedures. So the combined term that we are now going to use and that is accepted internationally is KLEX. So I will be talking about what is KLEX and when do we offer KLEX and when can we add an extra to the KLEX procedures. So we have gone from conventional LASIK with the microkeratomes to a blade LASIK, then the blade-free LASIK, and then to a no flap or a KLEX surgery where it's a single step procedure with a single femtosecond laser making a lenticule in the stroma and which can easily be removed through a very small incision. So KLEX is a revolutionary new method for laser vision correction. It has a combination of a precise effective femtosecond laser and lenticule extraction. So it is flapless, all femto and a single step procedure. So like in a with flaps, we of course require 2 machines, either a blade or a laser and an excimer. But now with the lenticle procedure, you just require 1 laser, and also the advantage it is not affected by the humidity, the temperature, because there is no excimer involved. That is also an advantage. So this is how basically a lenticule is shaped. There are 4 cuts, that is the posterior cut, the anterior cut and the side cuts. In this image you do see that the first one, that is the green, is the posterior cut. This is a lenticle that is plano-convex. What I mean by that is that if you look at the undersurface, the green surface, that is plane, that is flat, while the upper surface, the blue one, that is a curve, that is a plano-convex lenticule. But now with the Elita, that is a silk surgery we have by Johnson & Johnson, we have a proprietary biconvex lenticule. That is both the surfaces of the lenticule are going to be convex. Just like you have a high definition camera, the lenses are biconvex, they cannot be plano-convex. Similarly, we are making a biconvex lenticule in the cornea, which is hence removed. So this is just a procedure. On the left we have the Elita, on the right we have the Visumax. So you can see that in the Elita, so in the Elita on the left, once you dock, there is a different laser pattern. You do have a cyclotorsion compensation and you can center the lenticule. Once it is docked, that is the advantage of the newer femtosecond lasers. The Visumax did not have that. Of course, because we are also thinking of giving the patient 6x6 and 6x5, so we have to treat this astigmatism as well. So once the laser is fired, then on the right, I am going to show you the procedure, that is the Visumax. You have the posterior cut and the anterior cut. This is the side cut now happening. You see the edge. And once the laser fired, the surgery is pretty simple. You just open up the incision. The critical part is finding the anterior and the posterior plane. Once you find the anterior plane, take your dissector inside, and with the increased surgeon experience, this becomes pretty easy, and within a matter of minutes, the lenticule can be out. Once the anterior plane is dissected well, you go beneath the lenticule into the posterior edge and dissect it well, and the lenticule can easily be removed. So in eczema, of course, you had some challenges with the humidity and temperature, like I mentioned, and also there could be a peripheral loss of energy compared to the central, and also the chance, the jury is out whether the chances of keratosis are higher in a lenticule or not. But yes, in KLEX, the chances are lower given the literature, but yes, no one does like to report the ectasias, but yes, what is reported till now, there are lesser ectasias with the KLEX compared to an eczema. Confocal microscopy, KLEX, at the end of 1 month, you can see how the nerves are being regenerated. There has been extensive work done by Ryan Nethrale with Dr. Shetty that compare the regeneration of nerves at 1 month. Sensitivity also it regains very well with the KLEX. We do know that yes, the anterior stroma has the most amount of biomechanical strength in the cornea, and what we are doing is we are essentially making the lenticule in the mid and the posterior stroma, and we are leaving part of the anterior stroma untouched, which is not the case with the PRK and a LASIK. So yes, yes, we can say that there can be better biomechanical superiority, which we can see with our hysteresis and the Corvus. So no flaps, of course, no, there are no flap-related complications, no flap wrinkles, lesser chances of ingrowth. I won't say no chances because we have had ingrowths in our lenticule cases also. No microstriae, and DLK, of course, is lesser. So KLEX versus LASIK, there are many advantages. Single step, single laser, no chance of any aberrations with the weather or the humidity or temperature. Lesser post-op inflammation, lesser cut, smaller cut, so lesser chance of infection, and no chance of flap-related complications. So now that we know that yes, KLEX is here to stay, and there are multiple platforms that are trying to stay in the market. Now, once we get our patient to go and agree for a KLEX, should we not, or should we add an additive procedure, that is an extra procedure? What is an extra? An extra is a LASIK removal or a lenticule procedure combined with the cross-linking. So on one hand, we are doing a weakening procedure, and the secondly, now we're talking about combining an extra to make the weakened cornea stronger. So now, is it actually required? Yes, the jury is out. It will always be a matter of discussion whether we do need it or not. But yes, we know that there is a 14 to 33% corneal weakening due to the flap creation itself. We're not talking about the excimer. This is just the flap creation, because the Bowman, yes, does get irritated. There can be, if we do just the laser vision correction, there can be regression and iatrogenic ectasia. So what are the cases when we do expect an ectasia? According to the Randleman's ectasia score, yes, preoperative high myopia or hyperopia, thin corneas, the abdominal topographies of the formed frustes, the eye rubbing, pregnancy. There are centers that are not doing tomography, they are still doing topography, and we get those complications with us. And certain with hormonal balances of pregnancy, we know, yes, that is an established fact that there can be chances of ectasia after pregnancy. So on the left, you see a cornea that is not cross-linked, and on the right, you see a cornea that is cross-linked. So yes, there are visible changes immediately. Our group has also discussed about a lenticule addition cross-linking, where we use a lenticule to do cross-linking. So we can see the lenticule gets taut immediately after cross-linking. So yes, theoretically, the cornea does get stronger. So it reduces the chances of regression and also risk of corneal ectasia. But do we actually need that extra procedure? Apart from the biomechanical advantage, simultaneous cross-linking may also lead to less epithelial thickness increase, which is also a cause of regression. So yes, the extra, I'm talking about the points that are in favor of extra right now, that we can have a decreased chance of ectasia and we can have a decreased chance of regression also. But the concerns are, of course, whether it is safe, what about refractive effect, because we are talking about patients who had a preoperative 6x6. If we do, and we know the complication of a high power which we treat by an excimer, the chances of haze are there. And also if we do another procedure which is a cross-linking, which also has a chance of haze, we can have a double haze. So that is also one issue that we are facing. And long-term outcomes, do we have progressive flattening with the cross-linking? That could lead to a hyperopic shift. So who is a candidate? Dr. Shrital Babrar and Dr. Sri Ganesh have described very beautifully who is a candidate who should opt in for an extra procedure. You see that this is, of course, age, younger age, high myopia, thinnest pachymetry, the residual bed less than 275. Of course, if we do have a biomechanical machine, the TBI, and also any patient who have 2 or more of these factors should go in for an extra procedure. So SMILE extra, if we do a SMILE extra or a KLEX extra, we do use the dye, which is the thinner dye that does not have dextran. We fill the pocket with the dye. Now, another issue is that all the surgeons out here will have a different protocol. No two surgeons will have a different protocol. So that will have a same protocol. That is one issue. So we do take 0.25% riboflavin and inject it in the surface for 60 seconds. I'll just show you a quick video. So this is once we do a KLEX and the lenticule is removed. Once it is removed, we fill the dye is injected for 60 seconds, and then we cross-link the cornea for 90 seconds. We use half the energy required for a normal cornea because this is a already weakened cornea. We use only 2.7 millijoules. And of course, very important is that we have to irrigate the interface, and once it is irrigated, then we show the ultraviolet light. So these are results that have shown some improvement of vision and also no chance of ectasia for long term. On the right, you can see Sil Extra may be equally effective as compared to just a smile. So now, is smile absolutely necessary? Extra absolutely necessary. So of course, there are no specific indications. The jury is out whether we go for a extra procedure or we switch to a phakic procedure, phakic lens procedure. There is a vague definition of a borderline cornea. There is no guidelines. There are papers, but yes, we have to follow it as a very case-based approach. Subjective decision, no consensus of safety, and not a lot of data on hyperopic extras. So the protocol.
I think we should.
Yes, I'll just
conclude
give me a minute,
because
sir. I'll just wrap up. So I just want to ask a couple of questions. That is there a need for an extra procedure? Why is there no single consensus, and how should the refractive society find one? Also, why not perform in all cases? And does stiffening help in the normal cornea or the pathological cornea? And should we go for a phakic IOL? And lastly, would you get it done for yourself?